There is a moment in my office that happens almost every week. A patient sits across from me, leans forward, and asks the same question. Doc, what does surgery actually do, and how long until I can walk again? If you have been told you have lumbar spinal stenosis, if conservative care has not worked, and the conversation in your last appointment turned towards surgery, that's the question you're really trying to answer right now. And I want to give you a straight answer. In the next 10 minutes, I'm going to walk you through exactly what a lumbar decompression surgery is, what we actually do in the operating room, what the first 24 hours after surgery looks like, and what recovery looks like week by week, out to 3 months and beyond. No marketing language, no best case scenarios, the real version, the one I give patients in the consult before the surgery. I'm Dr. Omar Ramos. I'm a fellowship trained spine surgeon at Twin Cities Spine Center, and lumbar decompression is one of the most common surgeries I do. I'm going to talk about it the same way I talk about it in clinic. Here's the first thing to understand, and it's the thing that patients get wrong most often. This surgery doesn't fix your back. Lumbar decompression takes pressures off your nerves. That's the entire job. We are not straightening anything. We are not putting screws in. We're not fusing two bones together. We're making more room for the nerves that have been getting squeezed. What we actually remove is a piece of the bone called the lamina, the thickened ligament behind it, the ligamentum flavum, and sometimes a small part of the facet joint, just enough to free the nerve, through a small incision under magnification. Depending on your anatomy and how many levels are involved, the surgery might be called a laminectomy, a laminotomy, a hemilaminotomy, or a unilateral approach for bilateral decompression. Different names, but the same core idea: make more rooms for the nerves. Now, there's a related surgery called a fusion that does include instrumentation or screws and rods and does lock two bones together. That's a completely different operation with a different recovery and different trade-offs. I'm going to dedicate the entire next video in this series to comparing decompression and fusion head to head, so I won't get into it today. The next thing to understand is who actually benefits from a decompression, because not everyone with stenosis on their MRI is a surgical candidate, and not every kind of pain responds the same way to surgery. Decompression targets nerve symptoms. That's the language to remember. Nerve symptoms are the leg pain that builds up when you walk and goes away when you sit, the numbness or tingling in the calves or feet, the feeling that your legs are heavy or weak halfway through the parking lot. That's neurogenic claudication, and it's what decompression is designed to fix. Back pain, pain in the lower back itself, is a different story. Decompression can help with back pain in some patients, but it's less predictable. Patients whose primary problem is leg symptoms with walking are the ones who tend to do the best. Patients whose primary problem is back pain at rest, that's a different conversation. And here's the framing that matters most. The decision to operate is not driven by MRI alone. It's driven by what you are experiencing combined with what the imaging shows. A scary looking MRI in someone who's still functioning fine doesn't necessarily need any surgery. A modest looking MRI in someone who cannot make it across a room can absolutely benefit sometimes from surgery. The two together, your experience and the imaging, that's what allows us to complete the story. Okay, let's get into the part most patients actually want to know. What happens on the day of surgery, and what does recovery actually look like? I'm going to walk through it the way I walked through it with my own patients. Here's how this typically breaks down. For a relatively healthy patient, having a 1 or 2 level decompression, this is an outpatient surgery, which means that you go home the same day. For a patient having more than 2 levels, or older patients with other medical conditions that need closer monitoring, an overnight stay is more common, and you go home the next day. You stop eating and drinking the night before. The morning of surgery, you'll get checked in, we'll go through the consent, and I'll mark the surgical site with you before we go back. The surgery itself for a single level typically takes around an hour. When you wake up in recovery, the goal is to get you up and walking that same day. That's not me trying to be impressive. That's actually part of how decompression recovery works. Early walking helps prevent blood clots, helps your back feels better, and is a sign that the nerves are doing what they should. Many patients are surprised by how much of their leg symptoms are gone within hours of waking up. The pressure on the nerves is off. The pain pathway changes immediately. That doesn't mean you're not sore from the incision, you are, but the burning, the heaviness, the claudication symptoms that drove you to surgery many times start lifting right away. Here's what the timeline actually looks like. In the first 3 days, you're home, you're walking around the house in short bouts, 5, 10 minutes at a time, multiple times a day. You're transitioning off of the stronger pain medications. You're keeping the incision clean and dry. You're not driving yet. By the end of the first week, walking distance increases. Most patients are surprised by how much they can do and also by how quickly fatigue sets in. That's normal. Your body's putting energy into healing the surgical site, and many times you've also deconditioned while dealing with the problems in your low back. You'll have a wound check around now to make sure everything is closing and healing properly. Weeks 2 through 4, walking is now a real part of your day. Many patients can return to desk work in this window, sometimes earlier, sometimes later. It depends on the job and the commute. There is a phrase I use a lot in this period: BLT, no heavy bending, lifting, or twisting. And one of the main reasons for that, beyond the obvious one of not re-injuring yourself, is that the soft tissues need to heal. The muscles we work through, the fascia, the surgical site itself, those tissues are knitting back together in these first few weeks. And aggressive bending, lifting, or twisting interferes with that healing. Walking helps it. Lifting a laundry basket may fight against it. Around weeks 4 through 6, physical therapy typically starts. Gentle strengthening, posture work, and gradually rebuilding the endurance that being immobilized for years probably took away from you. By weeks 6 through 12, most activities come back online. Patients in physical jobs such as construction, nursing, anything with lifting usually return to full duty somewhere in this window. Travel is reasonable. Exercise beyond walking is reasonable in a structured way. Looking out to 3 to 12 months, this is when most patients reach what we call maximum medical improvement, the point where what you've got is what you've got. Most patients land in a much better place than they were before surgery. Not pain-free necessarily, not 25 again, but the thing that was stealing their life is back in their control. I would be doing you a disservice if I didn't talk about risks. Decompression is a generally well-tolerated surgery, but it's still surgery. The risks I talk about with patients before we operate include infection, which is uncommon but real, a dural tear. This is a small leak in the lining around the nerves, which can usually be managed at the time of surgery, but may extend the recovery a little bit. Bleeding, and longer term, the possibility of symptoms recurring or new problems developing at adjacent levels of the spine over years, because spines keep aging whether we operate or not. These risks are the reason this isn't a first-line treatment. Conservative care comes first, given that it's much lower risk. Decompression is what we offer when conservative care has been given a fair trial and the symptoms are still stealing the quality of your life. When I'm talking to a patient about whether to schedule this surgery, what we're really negotiating is what good looks like for them. For most people, good looks like making it through Costco without sitting down multiple times, standing through their grandkids' recital, walking the dog around the block, sleeping through the night because their legs aren't burning, getting to the end of a workday without the last 2 hours being a countdown of pain. That's what I'm aiming for. Not perfection, not pain-free, is the version of your life that stenosis took away from you, handed back. If you have made it this far, you're probably someone who's actively making this decision or supporting someone who is. The next video in this series is the one I would watch next: decompression versus fusion, and how to know which conversation you're actually having with your surgeon. I'll link it in the description as soon as it's live. And if you're in the Twin Cities and what I've described in this video sounds like your situation, the link in the description is how to schedule a consult with my team. We'll review your imaging, talk through what's going on, and figure out whether surgery is the right next step or whether something else is. Take care of yourself out there. I'm Omar Ramos. I'll see you on the next one.